And welcome. It is now May 2nd, 2024. I'm Dr. Duke Majan. Our patient is having a posterior cervical laminectomy for decompression and fusion. He is not a candidate for the laser surgery. Unfortunately, the bone spurs are too large, and there are patients like him we do encounter who we cannot do endoscopic spine surgery for. We have to do an open procedure to treat their problem. He's one of them, retractor. So I have Dr. Patel here assisting me. Our patient is asleep. He has a tube down his throat. He is, as we say, intubated and under general anesthesia. We are doing monitoring, intraoperative monitoring, and we're going to basically expose the spine. Then we're going to do a laminectomy, foraminotomy. How's blood pressure? I need more muscle relaxation. Okay, got way too much movement here. Yeah, we hit the patient hard with muscle relaxation in the beginning, and then we let it kind of wear off. You can actually see the muscles twitching. So this part of the surgery, for those of you who are unfamiliar with how surgery works, is called the exposure. And we've already completed the anesthesia, intubation. We've completed the positioning, the prep and drape. And now we're working on the, let me know when it's in. Now we're working on what's called the exposure. And what we're exposing is the part of the body we're operating on. So since we're operating on the cervical spine from the back, we're exposing the back of the cervical spine. Now, the back of the cervical spine is called the lamina and spinous processes. You can see how much more invasive this type of surgery is for the patient. All right, I do need probably, if we can maybe drop the table a little bit, like the Trendelenburg. Hit Trendelenburg. There you go, a little more. That's it. That should be good, yeah. Got a little vein that's bleeding. When you're doing surgery, it's important as a surgeon to know where your bleeding is coming from. And the reason for that is every source of bleeding has a different treatment. Okay? Let's see. So you want to identify the source of bleeding. I think that's better on the muscle relaxation. Ideally, you want to stay in the middle because you can see there's no muscle in the middle of the posterior spine. So by staying in the middle, you stay within what's called the fascial plane, and you can avoid a lot of the bleeding that happens in the muscle. Plus, you can avoid a lot of the pain, the post-op pain. So my goal here is to try to stay out of the muscle as much as possible, going between them. Sometimes it's hard to do. With my left finger, I'm feeling the spine. You want to be literally right on top of the spinous processes. Hold on. I'm going to reposition my retractors and go a little bit deeper. These retractors are pushing aside skin, fat, and fascia and muscle. Okay, that's what they're doing. All right, I'm palpating for C2 and I can feel it. C2 is the top of the cervical spine. There is a C1. You can't feel the spinous process of C1. Let me have the knife. I'm going to open the skin a little bit more. Okay. So we can have a better access, Bobby. So the knife is a scalpel. It has a sharp blade, but it doesn't coagulate or cauterize the blood vessels. So when you cut, you will get bleeding, as long as there's blood vessels there. The bovie, on the other hand, will coagulate blood vessels as you cut. So it does two things. It cuts and it coagulates bleeding blood vessels. All right. So far, looking good. I can feel the spinous processes. Now I will tell you, if you do this surgery the right way, it can be done very safely, very effectively, with minimal post-op pain. Cobb. All right. At this point, we're right on top of the spinous process. So what I'm going to do now, and sorry, we're not broadcasting from my headset, but I didn't want to today. I need to just work without the headset. Again, knowing where the bleeding comes from is very helpful. This is called a posterior cervical laminectomy infusion. Once again, this patient has pretty severe degenerative disc disease with associated narrowing of the spine called stenosis. We have gel foam soaked in thrombin. All right. No, I need a scratch pad right here. Oh, there. By the way, I'm using an eye system called Loops for those of you who are noticing. It helps me see a little bit better by giving me what's called magnification. And this part of the surgery is, again, the exposure. And what I'm exposing is the bone. The work we're going to do is really bony work, removing bones that are basically pinching nerves. And once again, it's called a laminectomy. In addition to the laminectomy, we'll be doing what's called a foraminotomy, where I'm opening the neuroforamen so the nerves have more room. He has pretty bad narrowing. All right. At this point, I'm not certain of the levels that we are at right here, but we're going to be able to verify that shortly. I have Dr. Patel assisting me. Any questions, Henry?
Yes, we have a question from Lanu on
Why is
YouTube.
there dinging in the operating room? I hear somebody's phone dinging. How's our blood pressure? 111. Can we get it down just a little bit? All right, Lanu.
Lanu asked, has any surgeons wanted to adopt your method of surgery even though it's already patented?
Well, thanks, Lanu. First of all, not all of our surgeries are patented, but this particular surgery is a surgery that's done by other neurosurgeons, but the way that I do it is very unique and I think better for the patient. We have less bleeding and fewer complications. Really got to keep my systolic at less than 110, like around 100, highest, okay? Otherwise, it's going to be a really difficult surgery to do. So that's the muscle relaxation and blood pressure control. two top priorities. All right. Lanu, I don't know. I mean, I think people have this they have this idea of doctors, which I had the same way, of wanting to do everything the best way all the time and being what's best for the patient. We still have way too much muscle contraction. I need more muscle relaxer. And the reality is, unfortunately, the doctors, once they're trained, once they complete their training, they don't really try to improve usually anything. They just go and they get trained, and they just take what they learned in their training and they go out and they use it every day. And the reality is there's many different ways to do these surgeries. So the really good surgeons do it really well, and then there's a lot of really not so good surgeons who don't do it very well. And the ones that don't do it well, they don't know they're not doing it well. They don't believe they're not doing it well. If you told them they're not doing it well and they could improve on it, they wouldn't believe you. So there's an ego issue there. Okay? Me, I knew that there was room for improvement in my technique years ago, because even though I trained at the top neurosurgery training program in the world at the time, I recognized my patients had a lot of pain after surgery. And so the pain, maybe Dr. Patel remembers, the pain was horrible. And when I started to investigate, how's our blood pressure? Huh? When I started to investigate, like, how to get rid of that pain for the patient, I discovered there was no way to get rid of the pain. Bipolar. Nobody had an answer, so I had to come up with an answer myself. Bipolar is not working. Okay. It's on 40. Suck, please. I think it's just the blood pooling. Go ahead. I need you to suck that blood, Dr. Patel. Give me the Bovie. Alright, let me see here. I can't see it, Patel. You gotta suck it for me. I gotta be able to get my Bovie in there. Come out. Don't suck my clots off. So what I'm saying is that every surgeon does this surgery differently. If you watch my surgery moment to moment, you'll never see another surgeon do it exactly the same way. We all have our own unique little differences, but the differences are important, because if you're doing something that is different but it's not better for the patient, then the patient's going to end up suffering as a result. So in the perfect world, surgeons would all meet with each other like they do on television, and they would talk to each other and figure out, oh, what's the best way to do that surgery? But that's not what happens, okay? Unfortunately, it's not what happens. All right. It's still spinous process, huh? Pretty crazy how big it is, right? So, still have a little too much muscle contraction. Yeah, you're not going to have twitches, but I am. I need you to give him some more. Okay? I know you've done 3 of these, but I've done 500, and I know exactly what I'm talking about. And I always have the same argument with the anesthesiologist. Your twitch monitor is not as sensitive as looking at the muscle and watching it twitch. You know what I mean? And the problem is the muscle's twitching, it's bleeding. A lot of scar tissue here from inflammation on the facet joints. I need to see here. Suck. Suck, suck. Come on, get that. You gotta suck it. I can't bovie through blood. Hey, it's in and out, in and out, in and out. Suck. It's in and out like a sweeping movement so that I can see the bleeder. Make sense? So if you just keep it there, and I can't see the bleeder. If you don't put it there, I can't see the bleeder. Right? So it's got to be in and out, little technique. That's kind of what we were talking about with the question is, you know, the technique, in and out. Surgeons understand that concept, using suction, in and out, in and out. Because if you keep your sucker where the bleeder is, then you're only going to see your sucker, not where the bleeder is that you have to coagulate. On the other hand, if you don't put the sucker there, then all you see is red. Right, Davis? So it's a dynamic process. And that's what I'm talking about, by the way. When we talk about differences in technique between different surgeons, it all depends. It doesn't even matter where you train. That's important, but that's not going to determine ultimately your technique. It's how you pay attention and what your goals are, what your expectations are. If your expectations are low, then you're going to have bad outcomes. Most surgeons' expectations for this surgery are low. They don't consider this to be something that can be done successfully without major problems. Suck here, please, suck. Okay. So the reason we're having the bleeding is, and it's not a lot of bleeding, but it's because there's so much arthritis in the joints right here, right where we're working, and that's caused neovascularization. Suck, please. Right here. Right here is where the bleeder is. And it's caused scar tissue. I gotta see. By the way, this is, in my opinion, the hardest part of the surgery. For the surgeon, that is. Suck here. Believe it or not, once this is done, I gotta see. Once this is done, the rest of the surgery is not so bad. It's pretty straightforward. Suck. Suck here. Right there. The bleeder is not here. It's not medial, it's lateral. That's why you got to suck laterally. It's over here somewhere. All right. Suck, please. It's just a pool of red. I need your help. Yep. Here you go. So it's his vessels are just very friable. You have bone wax too? Huh? Tuck, please. Let me have some bone wax. Oh, damn. Kitty. Kitty. So, freaking bony bleeding. That's why it's important to know where the bleeding is coming from. You won't be able to stop it otherwise. Wonderful. All right. Well, let's put in our cerebellars. Take this. I'm going to try to get a cerebellar in. I remember when they started another surgeon at Parish Medical Center. Davis, you hear this? I won't tell you the name of the guy, but he was a neurosurgeon, but he's not trained like me. He was a DO, and nothing against DOs, but they're not trained the same. And he was doing one of these cases, and unfortunately he got lost. I need another step up. Unfortunately, it's just a little bit too high for me, the patient. Let's put another step up. Huh? Yep, right there. So anyway, he, make sure it's connected. Yeah, otherwise I'm going to be on the floor. There's a way they interact. Uh-huh. Any other questions while we're here?
Yes, we have a question from Lanu, once more on YouTube. Asking, just curious, do you allow students to tour your wonderful facility?
What kind of students, Lanu? I mean, we allow students to work here. Huh?
Put both feet on your left, on the left. Step over to your left.
Yeah, we have students come. Tuck, please, here. We have students come and work.
They replied back, medical students.
Medical students, yeah, we do. As a matter of fact, I don't know, I don't talk much about this, but I am a faculty at the medical school here in Orlando. So is Dr. Patel. We don't get paid, we volunteer our time. And we have, what is that, coming from the facet joint? Just a diploic bleeder? Jesus, fucking diploic bleeder, man. Unbelievable. Diploic bleeders are bleeding that happens where there's an emissary vein that comes out of the bone. And you cut that vein as you're peeling the muscle back. Because remember, the bone gets, it's got bone marrow, and it's got, it has to get the blood out of the marrow, right, to the body. So, right. This is, again, the slowest, most painful part of the entire operation. We're making progress, slowly but surely. Bipolar. Yeah. So we have different tools for stopping bleeding. And the Bovie is one. It's a other name for it. We call it the hot knife. Because it is a knife, it cuts, but it also coagulates. Then you got the bipolars, like I'm using. Very common tool used by neurosurgeons to stop bleeding, arterial and venous, capillary. You have to cook the tissue between the tines, which are the tips. And just in this area right here, it's very common to get veins that bleed. Right where I'm working, it's just to the side of the spine on both sides. These veins are huge in this area, and they basically carry blood between the muscles, left and right, and they're part of our vascular network. And if you bipolar these right here, like I'm doing, before you cut them with the Bovie, then you can usually save yourself a lot of headache of bleeding, a lot of bleeding. So one of our goals here is to do the surgery with minimal bleeding. My typical blood loss on a PCDF is around, what was that, something? 25 cc's, 25. Any other questions?
Yes, we have another question from Rita on YouTube, asking, "Hi, I hope your mom is doing well. Does
Thanks, Rita.
this patient need a physio after this, and how long is the recovery? This looks very different from your usual surgery."
Yeah. Thanks, Rita. So Rita, just most people don't know this, but I'm trained in all types of spine surgery. And I've done the most invasive types to the least invasive types, and I like doing the less invasive because it's better for patients, but sometimes we don't have a choice, and you have to do the best surgery is an invasive surgery like this. The recovery is considerably longer. It's going to be several months. I think that's 4, I think that's 3, and I think 2 is right here. Okay. But I think that's 2 right there. Right there. And I think that could be 3. Let's see. It's really hard to tell. But this looks fused, doesn't it, Patel? So he's had a fusion, by the way, elsewhere. I did not do his fusion. There's his facet. It's very abnormal. See, guys, you got to see a facet joint right there. That feels like 2 right there. Let me do a little more on the exposure. Is Jordan here? Yeah. Where is he? I may need him. Maybe. Yeah, let's get him here. We got the fluoro in the room, right? Let me have some bone wax again. What? Bone wax on a kitty. This one emissary vein is just so stubborn. Come out. It's good to heat the bone a little because it melts the bone wax a little better. All right, so he's got so much arthritis. That's mobile, right? I see movement, yeah. Huh? Yeah, right? That's got to be 4, that's got to be 3. That would make that 2, which I don't feel another spinous process north of that. I feel like C1 posterior arch, right? There's nothing up there. So it's empty above. That means that's C1 up there, which means this is C2, right? So you agree that's C2. That's C3, C4, C5. So we're just about ready for the drill. And what I'm going to do is I'm going to do what's called a laminectomy. for amyotomy, but I'm going to reposition my retractors first. So if you study my technique, you'll understand this is the most efficient, safest, best way to do this surgery. But if you watch another surgeon do it, you won't see them do the same thing. By the way, the hemostasis is beautiful right now, Dr. B. And you can let that muscle relaxer wear off now, because we've pretty much done with the exposure. We just need another minute and we'll be done. Now the exposure has to be wide enough so that I can do the decompression, the laminectomy for amyotomy, but also so I can get the screws in. Suck, suck, irrigation. All right, so C2, 3, 4, 5, and then beyond. And we're only doing basically 3, 4, 4, 5. Suck here, I need to see this. See the facet joint right there, right? Take that. So, yeah, there's movement, you agree, right? That needs to be treated. All right. Let's do a laminectomy. Let me have the large bite first. These tips of the spinous processes are overgrown. Is Jordan here?
Jordan is here. He's getting ready.
Jordan, I think we're okay. Yeah, I think we're okay. I think we know where we are. Yeah, we're good. We're good. We're good. Thank you, Jordan. So I'm going to take these spinous processes are kind of weird. They're flaring out, and in doing so, they're going to make it harder for me to do the laminectomy. So I'm going to just take these little nostrils off, and we need the drill. At this point, I'm going to perform the laminectomy. Maybe I can have a retractor here. So you always want to, let me have a Wheatie. You can always, you want to make sure as a surgeon you optimize your field. And what that means, you want to be able to visualize everything as well as you can. And you want to have the exposure done really, really good. One more Wheatie. And just don't suck too much, because we don't want to suck the blood clots off. Otherwise you'll stir up bleeding. It's one of the things that you always, Wheatie. Can you guys see okay, Henry?
Yes, we can.
How is the view? Oh, I guess it's not great. Unless I put my light there, right?
Yeah,
yeah,
with the light it looks great.
Uh-huh. All right, so, and by the way, most spine surgeons will do maybe 10 of these in their career, 10 of these type. I've done 500. And they do it only 10 because, number one, half of the spine surgeons are orthopedics, and they don't do this kind of surgery. And second of all, most neurosurgeons are not comfortable doing this kind of surgery because it's very high risk. Where's my pedal for my drill? Is that it? All right. But if you're very, very well trained and you know what you're doing, then you do these surgeries because it's the best option for certain patients. Spinal laminar line right here. And so I'm going to start by performing my laminectomy at the spinal laminar line, which is the junction between the spinous process and the lamina and the facet. Good job, Dr. Patel. You see the diploic bone on there? How's it looking to you? Good? Patel? Looking good? How's your visibility? Good? Alright, so here's my lateral mass. Yeah, I can understand how some of these people would think, I don't normally see this, Dr. Duke, doing this kind of stuff. You're right. We usually do less invasive type surgeries. But like I said, sometimes you have to do this because some people aren't candidates. You won't have a good result. We always want our patients to have the very best results from our procedures. No, no, drill's not getting hot. Huh? Yeah. Good. I'm going to come to your side, Dr. Patel. Does Patel have 2 step-ups or 1? 3. I need you to take 1 step up off Dr. Patel, and I'll need the drill pedal moved to his side. Any questions? Hey.
No current questions, but we do have a comment from Lanu once more on YouTube saying the live broadcasting is amazing. It's very clear with high definition. We really appreciate it.
Well, good. That's what we want. We want to teach. And yeah, I don't need the bipolar. I just need the drill. Our goal here is to give you the same experience that a neurosurgical resident would have while they're learning. And that's actually, we do a better job, and I'll tell you why. Are you sure those are locked? Is it locked right here? Yeah? Yeah? Okay, good. Thank you. So the reason why it's a little better here is, number one, you get a better view, because a lot of times the resident is learning by, oh, something is moving, by looking over the shoulder of the surgeon. Is it good? Yeah? All right. Just, it's sliding for some reason. All right. You hear the creaking?
Yes, we do.
Creak. Anyway, where's the drill pedal? I need that drill pedal here by my right foot. Uh-huh. Thanks. All right. And then the other thing that we do here that you don't see a lot of is we actually teach, right? I mean, unfortunately, a lot of surgeons don't like teaching their residents. They don't explain what they're doing or why they're doing it. I had to learn by watching. It's weird. I don't know what it is. It's a, I don't know what you call it. What do you call it, Davis? Where, I mean, I don't know how your experience was, but I went to a top neurosurgery training, and the attendings were pretty, I don't know if arrogant's the right word, but they just didn't like teaching. I mean, they would just expect you to learn by watching, you know? There was no explanation. So I had to learn a lot just from watching. Not me, just me, but everybody. So why is it top training program? Because we had the best surgeons. Not the best, I mean, in a way, I guess they're the best teachers if you are good at watching what they're doing. But the reality is they're not good at, like, literally teaching. You know? They had the latest techniques. They had, you know, the best procedures and technology, but they weren't great at explaining things to us. So we didn't really get that nice, you know, let me put my arm over your shoulder like you see at Harry Potter, Hogwarts. Oh, you just got to watch and learn. Well, so far, so good. Right, Patel? Let's see what we got here. This, by the way, is called the laminectomy. And the technique I'm using is called the no touch, because underneath that is the spinal cord. So ideally you want to not touch it. So there's two ways to do this. One is the old-fashioned way with a kerosene rongeur, and the other way is here, like so. The other way is the drill, and I prefer the drill. Let's have a coker. The drill is safer for the patient if you know what you're doing, but very few surgeons know how to do it. Whew, this is stuck down from scar tissue. Huh. All right, so we're released, and my God, look at the scar tissue. Look at the scar tissue on the dura, folks. That is amazing. It's literally strings of scar tissue from chronic inflammation. I wonder why this guy's been in so much pain. Anyway, I'm just trying to be very careful. Honestly, this is probably the worst scar tissue I've ever seen in one of these cases. And I've seen 500. So, that's horrible. You have a curette angled? Larger is okay. Yeah. I'm going to try to free up some of the scar tissue here. But unfortunately, we're sitting right on top of the spinal cord. So, it's not a great situation. My God, this sucks. So what causes all this is inflammation. All right, why am I having so much trouble here? I mean, this is so scarred in, huh? Right there? No. Let me just think for a moment, okay? Let me just focus here. Jesus Christ. No, this is arthritis. This is facet joint inflammation spreading centrally. Oh, there we go. All right, there's the lamina. C3 and C4, okay? Remember, he's already fused it. Oh yeah, it could be from his prior surgery. I apologize, yes. From his ACDF, bleeding, spreading around the back, causing scar tissue. You're correct. That's the spinal cord, folks, right there. And all that yellow stuff is scar tissue. This should be perfectly white. That just shows you the kind of, inflammation, what the damage inflammation does. Let's switch sides. I'm going to switch back. Let me just step down. So, bit unexpected. I knew he had inflammation. I didn't realize he had that much. You really can't see it on the MRI. It's not something that's visible. But 500 of these surgeries, that's the most epidural scar tissue I've ever seen. So, you guys got to be here for that. So at this point, we've done our decompression of the central canal and the lateral recess. I'm going to examine the foramen at this point because there could be foraminal stenosis, and I'm going to make sure the foramen are decompressed. Yeah, pedal down there. And then bipolar at the top. It's actually just for today. Once I'm done with the decompression, which will be done soon, we're going to move on to the screws and rods, and then we're going to do the grafting, and then we're going to close. Okay? So I've got about 25 minutes to 30 minutes before we're closed. 30 minutes. All right, so really impressive. Can you guys see this, Henry? All
we can.
this cheese is scar tissue, huh?
Really deformed.
Yeah, irrigation. This is a kerosene rongeur. It's one of our tools we use. And look at all that scar tissue. Holy macaroni. That's all scar tissue. All that cheesy stuff is scar on top of the spinal cord. Nothing I need to do about it at this point. I just want to open the foramen here and decompress the nerve root from the back. Take that. And then we're going to put our screws and rods. And then our bone graft. Because it ain't a fusion without bone graft. That's the ligamentum flavum right there. You guys see it? Oh, sorry. My big head is in the way.
We can see it, yes.
Right here. So I'm going out the foramen. That piece of bone right there is literally pushing on the back of the nerve. And then I'm going to go to my side. Dr. Patel is doing a phenomenal job of assisting me. Remember, this is the spinal cord. We don't want to have any issues right now. Can you see what I'm doing?
Yes, we can.
It's called a foraminotomy. Okay, this is a decompressive procedure done in the back of the spinal cord. I used to do these every week, by the way, before I got more into the laser surgeries. Every week we did these. Here, by the way, this is outpatient spine surgery. I forgot to mention that. There's no other neurosurgeon in the world that does these outpatient. We've been doing them outpatient now for 10 years. So why is that? Because it's too complicated for them to do it outpatient, but I mastered it outpatient. It's a technique I use and developed here at Duke Spine over the years. I've been doing these posterior cervical laminectomy and fusion for 26 years, and of course 26 years ago I couldn't do it outpatient, but I could start doing it outpatient about 12 years ago. We're done. So we're going to drill the holes for the screws, and let's just see your side at C5, your side C5. Yeah, good. All right. So the technique here is 20 degrees out, 20 degrees up. All right, what am I talking about? There's a 14 millimeter long exposure of the drill bit. You guys see that?
Yes, we can.
Okay. You sucked my gel foam. Bad Dr. Patel. All right, I'm going to start at the center of the lateral mass, and I like to start at the center and then go down just a little bit and in a little bit. You want to plant the drill guide, which if you could look carefully, you see the little teeth. It helps hold the bone. And I'm going to aim lateral, which is out, and up 20 degrees, okay? And that way you avoid hitting the vertebral artery and you avoid hitting the exiting nerve root. 20 out, 20 up. And if you do it this way, make sure you line them up good, otherwise you're not going to get the screws to connect properly. If you do it this way, then you won't have any problems. All right, where's the next one? Here. There's the lateral border. Yes, you agree? Here. Mm-hmm. 20 out, 20 up. So I'm right there, I'm connecting it to the prior fusion. So remember, he's had a prior fusion. Thank you. We won't need a 16. He's had a prior fusion. Oh, by the way, this is the screw. It's a self-tapping screw, so I don't need a tap burst. And it's polyaxial head, and I use Alphatech Spine products because they are the best still, in my opinion. And it's not just the implants that are the best, it's their equipment that's the best, the instruments. So I drill the pilot hole. I'm going to aim 20 out, 20 up to avoid injuring the vertebral artery. Can you guys see okay?
Yes, we can.
And the exiting root. And you don't want to make the mistake of putting it in too far, because the tulip head will lose its ability to move, and it'll become fixed. And you want to maintain polyaxiality. Now that pilot hole, the last one, is at the bottom of this construct, and it is at What?
No.
It is at C. Are you talking to me or?
No, Luis.
Oh. It's at the bottom of the construct, which is C5. Now I had to get it started by pointing down because it's a bit misshapen. Okay? Sometimes these screws are, these lateral masses they're not perfectly shapen right because we got arthritis here. And that's going to change the bone shape. Right? Arthritis does that. So, "20 out, 20 up." And if you use 14 millimeter screws, you can stay out of trouble. Some of these surgeons get a little carried away and they think, oh, I'll go longer. You don't need longer than 14. They'll do 16, 18, and then next thing you know, their screw is coming out the front of the neck. And I think it's, I don't know, stupidity or ego. But, they don't realize or they don't think about the fact they got a living human being that's in their care, that's totally defenseless against their stupidity. So they have to constantly, I constantly always check and double check what I'm doing mentally, to make sure I'm not harming somebody. And I've never harmed anybody with this technique. A lot of surgeons will get weakness in the deltoid after the surgery. Patients won't be able to lift their arms. And I've never had that with my technique. And we do this outpatient. This patient's going to go home in 2 hours. No one else in the world can do that. And we've been doing that for 10 years here at Duke Spine. And before that at the hospital for a couple of years as I perfected this technique. But yeah, long story short, I don't like doing fusions, but sometimes they're absolutely necessary. Speaking of which, I think we have another one next week, ACDF. Same story. Patient has 2 discs in her neck that are not going to be fixable with laser endoscopic. So I'm sizing up the rod right now. And we're going to cut this rod and then we're going to contour it. You guys see that? So
Yes,
this
we
is
do.
one of the implants for the surgery. So I'm sizing it, and Dr. Patel, hold on, let me just verify. Yep, okay, good. And then after we size it, we're going to contour it. Now the contour is important, right? Because if I put this rod the wrong way, the neck will be straight or kinked forward. I want to kink it back as much as possible. So I'm going to bend this rod in such a way that it will reduce the spine to the rod. Okay, you're reducing the curvature. We call it a reduction. And what we're doing is we're bringing the bone to the implant, bringing the bone to the rod. And by doing that, it puts the patient's spine in lordosis, which is what I want. Lordosis is a back curve. Okay, that looks pretty good. The rod is a little longer than I need it to be, so I could cut a little bit more off. Yeah, we'll just cut another 5 millimeters off. Dr. Patel. By the way, Dr. Patel has an incredible swing with the golf club. I'm a lot bigger than him, but he can hit that ball miles. I can't. I cannot. Never mind that I don't play golf, but even if I did, his technique is phenomenal. He's taught me so much. When you talk about technique is everything. Dude, that guy waxed the ball. You should come play. You should come to Orlando and play. Huh? Would you like to do that? All right. We'll get you out when Arias gets here. All right. I don't think it's cross-threaded. Can you see cross-threading? I mean, it could be. No cross-threading, right? You want to make sure your set screws aren't cross-threaded. They're looking good. Now, the final tightening will be done with a counter torque wrench, but we don't do that till later. So, I've got to size and cut and contour the next screw. Why don't you straighten those out? All right, I will. Any questions from our audience?
Yes. This next question coming from Big John on YouTube.
Oh, Big John. Big John. You're saving these, right?
Oh, yeah.
Hi, Big John. Good to hear from you.
They asked for first as a comment, said doing this kind of surgery makes DLDR look like a walk in the park.
Yeah, it is.
And then they asked, I have a couple of cervical DLDR related questions. First,
Sure.
when the patient is positioned on the operating table, how do you position their arms? By their sides or up over their head?
With DLDR, it's on the side. Like laying on your back, you just put your arms by your side.
And their next question, asking, post-surgery, when a patient has muscle atrophy and weakness with nerve issues in their arm,
Yeah.
what direction would you think the weakness and nerve reconnection would start? Meaning, start in the hands and slowly move towards the shoulder, or start in the shoulder and work towards the hands?
Yeah, great question. I think that the answer to that is going to depend on which, I may have been a little too aggressive there, but I don't know. I think I'm going to try it. I may need a reducer. I may need a persuader. Let me have the screw first. To answer your question, it all depends on which nerve was damaged the most, right? So, and then it depends on, you know, if they're all damaged equally. Let's say you had 3 nerves damaged equally, number 5, number 6, number 7. Then the muscle distance from the spine is going to be the determining factor. The muscle distance from the spine is going to be the determining factor. All right, so let me have a set screw first. So if the muscle is farther away, then it's going to take longer because the nerve grows the same speed, 1.4 millimeters per day. And then the last, so the first and most important thing is, are the nerves all equally damaged before the surgery? Ready? And then the second most important thing is how far away is the muscle? And then of course there's always the possibility that it doesn't heal. You know, it's always a possibility. There is such a thing as permanent nerve damage, unfortunately. And that does happen in some patients. You don't see any cross-threading, right? Here, it's good. So far so good. At this point we have placed our lateral mass screws. We have placed our rods, contoured them, and now I have placed the set screws, locking the rods to the tulip of the lateral mass screw, which is embedded in the spine bone. And we're ready to do our final tightening. After this, we're going to irrigate, and then we're going to drill the bone. We call it a decortication so that we can get a fusion done. And then we're going to put in bone graft. Now our rep is here from Alpha Tech, right? Is he in the room? What's your name? Evan. Nice to meet you, Evan. I used to do a lot more of these surgeries years ago. Is Alpha Tech still independent, or is it owned by some other company now? I guess Globus bought. Who did Globus buy? NuVasive. That was pretty shocking. I mean, I was around when Globus started and when NuVasive started. And so NuVasive started before Globus. I remember when Globus first started. They were going around trying to get surgeons to use their stuff. And they were offering incentives, financial incentives. Did you ever work for either of those companies?
I did work for NuVasive.
Yeah. When?
I'd say about 5 years ago.
Yeah, 5 years ago?
I prefer ASAP.
Yeah, I used to use a NuVasive product. Is Chris Walsh still around?
I'm not sure actually.
He was the distributor back when I was using NuVasive, back in 2004, 5. And the VP of marketing, he's now, I think he was the president, right, of NuVasive before they sold. What was his name? I can't remember. If you told me his name, I'd recognize it. Anyway. All right, everything's tight. At this point, we're going to irrigate, and then we're going to decorticate. Betadine. Got about 10 minutes left. Any other questions from our audience?
Yes. This next question coming from Robin on YouTube,
Hello, Robin.
saying, incredible work. What is the recovery time for this type of surgery?
Robin, it's a great question. To be honest with you, it depends on how you define recovery. This patient's going to go home in 2 hours. We call that recovery. When are they going to go back to work? He doesn't work, he's retired, but he could go back to work, say, in a week. Is he going to need narcotic painkillers after this surgery? Yes. Unfortunately, with fusions, they're so painful because of the muscles being cut off the spine. All laminectomies, all discectomies, all fusions require narcotics. Laser surgery does not, when we do it. All right, we're going to decorticate. Now we want the bones to fuse. To get them to fuse, we've got to drill out the areas where there are joints. There's soft tissue in there, and that soft tissue does not want to fuse. So we got to make it want to fuse. To do that, we're going to drill. And we're going to get some bone in there. Don't suck that. Let's see a cob. Cob. So this is part of fusing. You got to fracture the bone. And that's what we're doing. We're fracturing the bone. That's what the drill does. It's wonderful at fracturing the bone. I know. First time I saw it, I was like, what the hell? Right? But when I first started, do we have any bone graft? Yes?
Yeah,
Nice.
I mean,
No, it's nice. This is very good. So to get my bone graft in, see, this is the bone graft, by the way. It's a combination of autograft and allograft. Autograft, of course, is the patient's own bone, therefore auto, and graft because it's a tissue that we're sticking in there. And then there's allograft, which means, same species, bone from, another human, I believe, right? Cadaver. Anyway. Doctors don't like talking about those things because they don't want their patients freaking out. Oh my God, you're putting a cadaver bone in my neck. But yes, it's exactly what they do. Which is why, one of the reasons I don't like doing it. But, like I said, sometimes we have to. So I'm pushing all the graft down laterally. We're done. And now we're done with that. So, I already put the gel foam. I don't think we need more gel foam. All right, any questions as we're getting ready to start closing this wound? So we've completed our laminectomy. We've completed our instrumentation. We've completed our fusion. By the way, the word fusion is a little misleading. Hold on. Because fusion is actually when the bones fuse together, which hasn't happened, but we call it a fusion, but the real name is called arthrodesis. That's this technical medical term. And we're not actually doing an arthrodesis, the patient has to do it. It takes about 3 months to 6 months to arthrodesis, sometimes longer, depending on the patient's bone metabolism, health, nutritional status, etc. We're going to put a little bit of vancomycin powder because ever since I've been doing this, we've never had an infection. And here you go. We're going to put a drain. Okay, let's get a drain in here. Take that. We always put a drain for posterior, cervical, and lumbar. I use a number 7 JP drain. It has to go. Oh, of course. Now we have massive bleeding from the freaking drain hole. Give me a Bovie. Stupid. Unbelievable. Isn't it lovely? Alright. Sometimes just putting the drain in will stop that. Alright, unbelievable. Where's his blood pressure? So it's basically not the blood pressure. I need the mosquito. I need it. So, well, let's see if the drain will help us. Let's get in there, Patel, and go ahead and get that drain on there. Great. Okay, let's pull this through. So the drain will actually put some pressure on the bleeder. And you don't want to pull the drain out too much. Scissor. Scissor. Let me do it. Just want to make sure. And I like to cut the drain so we leave some holes. Okay. And let's close. I need suture.
Can we do extra?
Yeah, expo. But I need suture. Patel can do the expo. We're going to put some medicine that will help. It's not narcotic. It's liposomal bupivacaine, which is a local anesthetic, analgesic, and it will help him with his pain. Yeah. Oh no, because he's in pens, so we can't risk him, thrashing around coming out of pens. Yeah. Needle down here. Watch your hands there. So, yeah. You guys didn't see this, but this patient is actually pinned. His head is literally pinned in Mayfield. God damn. Let me have the drain stitch. This thing is unbelievable. It's just my luck. I need a mosquito first. Look at this. Scissor. We're prepped further down, right?
Oh yeah.
Suck, please. So we're going to lose more blood. This is just karma. We're going to lose more blood from the drain stitch, from the drain placement than the whole surgery. It's blood loss. It's just stupid. I mean, and it happens to me all the time. I don't know. How do I get so lucky to hit the one spot where there's like an artery the size of a New York subway underneath the freaking skin? Right? How retarded is that? Sorry, I know I shouldn't say that word, but I'm just a little frustrated right here. A little miffed. Anybody use the word miff? It's like an 80s term. Miffed. I'm miffed. Don't ask me how to spell it. Maybe Big John can give us some spelling.
I think it's 2 F's.
M-I-F-F-E-D? So, anyway, done. But I said it earlier that you've got to know where the bleeding is coming from in surgery. And a lot of surgeons don't. They don't understand it. Okay, they don't. I'm just telling you the God's honest truth. Why don't they? I don't want to tell you why, because everybody thinks I'm mean and nasty when I tell you guys the truth. But it's basically just a lack of caring, a lack of thinking, a lack of planning. Okay? And that's why a lot of spine surgery is still done in the hospitals, because surgeons don't know how to control bleeding. And that's one of the first things, that's the first thing you have to do, folks, as a surgeon, is you have to control bleeding if you want to do outpatient spine surgery. Because if you don't, help me out here please, then you can't send the patient home bleeding. So, where are the places they bleed? The skin, right underneath the skin. Okay. The muscle. The veins running between the spinous processes. The bone. The epidural veins. Emissary veins, like we saw today. These are all, of course, then they got the major arteries and veins, which I'm not going to talk about because you shouldn't be anywhere near them. But I was telling you a story about a poorly trained neurosurgeon who came to my hospital, recruited by the hospital because they wanted more business. They saw how well I was doing at the hospital, so they decided to bring in some competition and try to increase their revenue without my permission or without talking to me, which is a taboo thing, by the way. You always go to the existing doctor that works at the hospital and see if they want to collaborate in bringing a partner, but they didn't do that. They just hired this guy. He was very poorly trained, and he was doing this case just that I just did, and he was getting into massive bleeding, and he was lost. And the nurse came into my operating room. She said, "We need your help. Next door, this neurosurgeon is experiencing massive bleeding, and he doesn't know what's going on." And I'm like, fucking great. So I went in there, and of course he had nicked the vein. He was not even on the spine. He was to the side. He missed the spine because he didn't follow the principles. He wasn't trained well, and he never thought about it. But that's why training is so important. You know, you want to be well trained, and not all the training programs are good. A lot of them are bad. In neurosurgery, in my opinion, about 10% of the training programs are really good. 90% mediocre to really bad. So if you're in a top 10 training program, you're going to get a really good education, which really depends on your attendings. Right, Patel? It's just like Harry Potter. You know, if you got good wizards, you're going to learn good spells. Did I just say that? Really? No, I haven't watched Harry Potter lately. Oh, I wonder why my needle turned. All right, any questions?
No current questions, but we do have a comment from Big John once more on YouTube,
Big John.
following up on their second question with muscle atrophy and weakness with nerve issues in their arm. They said, for me, my hands came back first, followed by my arms, but my rotator cuff nerves are not back yet, but they're coming back very slowly.
Yeah, well, good for you. And, you know, again, it could be that they were just damaged more, you know. They were just compressed longer, harder, with more damage. It could be potentially a blood supply issue too, you know, to the nerve. Like you could have had better circulation to the other ones. Everybody's different. Hold on. So, all right, we've got almost everything. I got to put one more stitch down here. And this layer is the deep layer. It's actually the fascia. We call it fascia. You see this This stuff right here, this thick stuff, if you eat steak, it's that white stuff that goes around the meat. That's what I'm sewing right now, fascia. And that's what you're supposed to sew when you do these types of surgery. Now, I'll be honest with you, the first one I did, there was no instruction. They just said, close this wound. Come in here, Decompression. Get in here and close this thing. It was my chief resident who was a real a-hole. He hated me. And for no reason, by the way, not that I did anything to him. One more stitch here. And he said, close this thing. And he didn't show me how. And I had never closed one before. So the first thing I did was sew the muscle together. Because that was the deepest part of the wound. And yeah, it was the wrong thing to do. You don't touch the muscle with suture. It just cuts right through it. So you have to get the fascia. And the next time I operated, go ahead. I sewed the muscle, but it was with my attending. And he said, what the fuck are you doing? And I said, I'm closing. And he said, why are you sewing the muscle? I said, I don't know. I thought I was supposed to. He said, no, you never sew the muscle. It tears right through. So that's how you learn, right? And unfortunately, my fellow resident didn't teach me that. It was the attending, and he wasn't happy about it. So anyway, that's why our broadcasts are nicer than even what neurosurgeons get in their training, because I actually talk to you guys as I operate, which does not happen in most neurosurgery training programs. How was your training, Dr. Davis? Brutal. Oh, brutal too? Yeah, we had one of the most malignant neurosurgery programs. Where did you train? Ohio? Huh?
I was West Virginia.
West Virginia? Yeah. West Virginia had, well, I don't know if it was West Virginia or Virginia, had John Jane, who was the most malignant person in all of neurosurgery when I was applying. But his program was not the best. It was one of the top ones, but it only had 2 neurosurgery attendings that were any good, him being one.
Yeah.
Have you heard about him?
No, he would have been probably UVA then.
Yeah, he's at UVA.
Yeah, 'cause I was at West Virginia.
Yeah. So you had some bad experiences as well?
Oh yeah, I went to my residency party where we got our certificate with my truck pack.
Yeah, I heard. I remember you told me that.
Yeah, I got what?
With his truck packed, ready to get the hell out of there. Did they offer you a faculty position?
Nope.
They never offered me a faculty position. You know, what happened with me was and this happened a lot to other residents, the higher level residents, you know, the 7 years, 6 years,
Yeah.
they would just dump everything on the junior, which is fine. You know, we're used to that, you know, the lower resident. But then when they fucked up with the patient and the patient's like dying, they would blame the junior. But they wouldn't blame you in front of the attending. They'd blame you in the office. And they would say, yeah, that Decompression, I told him to look for vasospasm, and they never did, you know. But who's the attending going to believe, them or me? You know, attending's been with them for 5 years and me for 6 months. So we're the scapegoat, you know, the lower resident. Now, I never did that. I never did that. But, you know, it's just a character problem, you know. It's a problem with their character. It's nothing to do with the system. The system allows it. But it opened my eyes to what pieces of shit a lot of these neurosurgeons really are as a human being. They're not a good person, you know. Their clinical skills may be fine, but they're people-wise, they're just bad people. So I have literally 5 minutes, and then and then we'll get the drapes off, and then we'll be ready to get him out of pins, like flip him. All right, and then once he's flipped, we'll get him out of pins. So, any other questions, Henry?
Yes, we have a couple questions. This next one coming from Kane's Life 2 on YouTube,
Hello there. Welcome to our stream.
asking, what are my odds of permanent nerve damage? I had my second fusion on the 27th of February last year, still having burning in my left foot, back pain, been on pain meds for 13 years, tired of it, just filled out an online form, sending my MRI to you. I'm 46 years old, 2 fusions in 5 years. Second one was decompression of nerves. Take that, the first fusion was rebuilt with stronger hardware.
Yeah, great question. Hard to say, but I think you're right. You're doing the right thing and doing a free MRI review with me. I'll be able to assess better once I ask you some questions. One of the questions I'd want to know is, are your symptoms permanent, like always there, or do they get worse with positions, like walking, standing, laying? In other words, does movement change or fluctuate your symptoms? If the answer is yes, there is some fluctuation, that means there's a dynamic component. That means there's compression of the nerve still. That means it's fixable, in my opinion. It's when the symptoms really don't fluctuate much with change of position that I get more concerned for permanency. I don't know, can I get one more stitch in there or not, Patel? What do you think? No? Looks kind of small. No? No. Let's cut those and let's staple and let's get him flipped. So are there any other questions? We're done.
Yes.
I'll take the question. Actually, I'll come and answer them for you guys face to face. Are you guys good? Staples, bandage, and then come get me when you're ready to flip, or you can flip them. Yeah? Just call me when you're ready. Remember, you cannot move that body while he's pinned.
That's correct, yes, sir.
Otherwise, he'll snap his spine. Just remember that. All right, I'm heading over there. Great job.
Copy that.
Dr. Berndes, wonderful job.
I'm here with a gentleman who came to the Duke Spine Institute with horrible back pain, pinched nerves, symptoms down your leg, weakness, numbness, and using a walker. He's been struggling now for quite a while. You had the Duke laser disc repair done yesterday in the morning. We went in with the laser and we cleaned out 2 discs that were really causing pain in your back. They were herniated and starting to degenerate. How do you feel today?
10,000 to 50,000% better. Absolutely wonderful. I can't even, it's hard to explain. Going from not being able to walk 5 feet to being able to almost just walk around the block. It's one day. I mean, it's 24 hours. It's incredible.
And when did you realize you had this relief on your back?
Yesterday, when I got home and got settled down, and there was no pain. There was no pain in the back. There was no pain all the way down the leg to the big toe. It was like, where'd the pain go? It just dissipated. And that's after surgery. So usually you feel like there's surgery, there's going to be some pain. No pain. I can't even explain it.
Well, you're doing a good job. What was life like before you had the Duke laser disc repair surgery?
I didn't want to live this way. There was no way I would never want to live that way. Never want to, no. Excruciating pain. I mean, can't sleep, awake all night. The pain was constant, it never left, but you got so exhausted from feeling the pain that you would finally fall asleep. I would finally fall asleep anywhere from an hour to 2 hours at the max, and 2 hours was a gift. And that's all night long. I had to sleep in the room by myself because I would have kept my wife awake all night. I was just miserable, the most misery I've ever felt.
I met your wife. She's a lovely lady. She's by your side all the time.
Yes, sir.
It's hard when you have so much pain. It takes a toll on you, but also your loved ones.
Yes, it does. And she's been a God's gift. I will say that.
Now, how does she feel about your surgery you had yesterday?
She's very happy for me. She's been through every day of it. And this started before Thanksgiving. And we are 3 days from Christmas. And I'm going to have Christmas without pain. Thank you, God. Thank you, doctor. Thank you,
welcome.
everybody in the staff. This staff is unbelievable. Nicest people I've ever met.
Well, we care about people like you. We want you out of pain and happy and getting on with your life. And tell me about your job. You have an interesting job.
I do. I love my job, and I call it the greatest part-time job in the world. One of the highlights of my job is something I can say about it is it's a job where you can say no to work and you'll have a job the next day. It's the only job in the world that I know you can do this. I'm a stagehand with the International Alliance of Theatrical Stage Employees out of New York, and I love my job. I do everything from entertainment, theaters, arenas, to trade shows.
What's the best show you did?
I've worked with two out of 4 Beatles. I've worked with, everybody from Kenny Rogers to Celine Dion. I've worked with Van Halen. I've worked with all big entertainment. And then I've done a lot of medical trade shows, so I know where I'm at. When I come into a medical facility, I look around and go, oh, I know where that comes from, and I know where that comes from. And it's a great job. It's a wonderful, wonderful job. I see things before normal people see things. I saw the first flat screen computer and I didn't think too much of it because I wasn't a computer person. Now it's like, look at the flat screen TVs, and it's a great job. That's the trade show side. The side where what keeps our country moving is people buying and selling the products that we use, from the cameras that are on us right now and the lights that are on us right now to doctor's coat that he's wearing and the shirt that I'm wearing. So
and probably some
incredible.
of the equipment we used in your laser spine surgery.
Absolutely. The best shows I do, I have to say, are the medical shows, because I go around and I get literature and I read and I learn from past experiences with herniations. I've had double hernia surgery, so I know about that. I've had hand surgery, I've had knee surgery, now I've had back surgery. So I learn, and it's, you get to talk to the people that do the work and represent the products, and it's pretty awesome. So I love my job. I miss it. I honestly miss it.
Well, now you're going to be able to go back to work without that pain.
Oh, thank God. Thank you. Thank you, Doc.
You're welcome. Is there anything else you want to say to your fans out there?
If you're having issues, any kind of issues with back, knees, joints, you need to come to Duke Spine. You just have to. The Institute is wonderful. Everybody here, there is no negativity in this building whatsoever. It's unheard of out there. And I've seen a lot of doctors over the years for different reasons, but there's no negativity here. It's all positive, and you leave positive. So I'm very, very happy that I did this. And I tell anybody that has ever gone through any kind of pain, you need to come see Duke Spine. People come from all over the world, and now I know why. I just came from up the street, so I can tell you, up the street or from another side of the country, just come to Duke Spine. That's the best I can tell you.
Well, thank you for sharing your story. Congratulations and Happy New Year.
Happy New Year and Merry Christmas to the whole staff. All your people are excellent, to your family as well, and their families. And I hope everybody has a wonderful Christmas. And by the way, the office is magnificent. That is the best I've ever seen. That shows when you walk through this office for Christmas holiday, it's all about family. It's all about the holidays. It's about the people that come through.
Thank you.
Thank you
you very much.
All right, so what a great testimonial, and my God, my hair looks horrible. Thanks, Henry. You were supposed to Photoshop like a nice Conan O'Brien hairstyle.
I could definitely do that next time.
I'm Dr. Duke Majin, for those of you who don't know, and we have just completed a posterior, because we go through the back, versus anterior. You've probably heard of anterior cervical discectomy and fusion. Anterior is the front, posterior is the back. We did a posterior cervical laminectomy, foraminotomy, instrument infusion. And for those of you who watch me do laser surgery all day, or plasma minimally invasive, there's a reason we do those surgeries. They're better in 95% of patients, 99% of patients. But there is the occasional patient out there, maybe 2 or 3 out of 100, that they're just not a good candidate for the minimally invasive stuff we do, and they need a maximally invasive surgery. So I'm still the guy to do it. I've been doing it for 26 years, and I'm honestly pretty darn good at it. So I'm not trying to toot my own horn, but that said, I don't trust my patient's care to another surgeon for fusions, because the other surgeons are not going to do as good a job. If it was brain surgery, which I am a brain surgeon, by the way, I would send the patient out and then have them go to whoever the best brain surgeon is for that particular problem. Aneurysm, AVM, tumor, skull base, whatever it is, pediatric. But I am not the best brain surgeon for the job because I don't do much brain surgery anymore. And so I would refer my patients out. And I'm just explaining this so you guys understand why I don't do fusions all the time. It's not because I don't know how to do it, I'm not good at doing it, it's because they're unnecessary in about 98% of patients. That said, occasionally we have to do it. So what did we do? Well, this is the cervical spine and it's got some metal in it, so don't get distracted. But basically this patient has, so this is C1, okay, posterior arch, C2, C3, C4, and then C5, C6. He has a fusion at C5, C6, C7, but he developed adjacent segment disease. We tried a plasma rhizotomy to get rid of his pain, but it didn't work. He still had pinched nerves, and he was getting these nerve symptoms. So the plasma rhizotomy can't fix that. It fixes facet pain, but not pinched nerve symptoms. So I had to go and make a cut in the middle, get down on these bones. We peeled the muscle off these bones. You can see that on the video if you rewind it. Put the retractors in to open things up, and then you could see these bones. I then used a drill to make cuts, all right on the spinal laminar line, and remove these bones. That left the spinal cord. You could see the spinal cord in there, right? And you could see it where I took the lamina off. Then I opened the foramen with the kerrison, and then we put in screws, lateral mass screws, that's what these are, and then a rod and set screws to connect it. So we did a decompression with an instrumented fusion, and I also corrected his straightening of the spine above the fusion by doing a little curvature in the rod, so I could reduce the spine back to the rod and give him a little bit more extension, which is a more natural position of the spine, so it's more comfortable and less painful for him. We did all this outpatient. He's going to go home in about an hour and a half. He's waking up right now, and we didn't have any problems, but we did find a lot of scar tissue around the spinal cord, maybe related to his old fusion, where they did his PCDF in the past. I didn't do it, somebody else did, and a lot of these surgeons have bleeding, a lot of bleeding, and the bleeding gets around the spinal cord and can cause scar tissue. Anyway, yeah, questions?
Yes, this first one is a comment and coming from Kane's Life 2 on their follow-up about the odds of permanent nerve damage. The question that you asked them, they replied back saying, yes, they fluctuate. Laying and sitting are brutal, so that's encouraging to hear.
Yeah, so we could probably fix a lot of your symptoms, a lot. But you got to get the right surgery by the right surgeon.
And then next question coming from Sean on YouTube, asking, how is your movie coming along? I am going to be at Amelia Island Shrimp Festival this weekend doing a trade show. Come visit us, we do woodwork.
That's very sweet.
Yeah.
Thank you, and thanks for asking, Sean. Yeah, the movie's coming along, actually. I don't mind telling you all the name. The director and and it was mostly the director's idea. He wants to use the title called Spine Scam. Surprise, surprise, right? Spine Scam. So the name of the movie is Spine Scam, and it will be a docudrama, and we expect and think, and we don't know yet, obviously we haven't gotten confirmation, but we think that the streaming services are going to be very interested in it. When I say streaming services, Disney, Netflix, HBO, whoever, and that there's going to be a lot of interest in it because the script is now done. I have a few things to change on the script still, but I think it's really good. It's really interesting, and it's going to be a really good docudrama. We've got an hour's worth of it, and if it gets picked up, then it gets paid for, and of course I can then do the second movie, which is going to be about, I think the second one, we have so many things to talk about, but the second one is either going to be about interventional pain management doctors and how they're scamming everybody, using them as pin cushions and doing all these pain procedures that basically don't work and just generate money, and the venture capital's coming in and buying up pain practices, consolidating them, and then forcing the surgeons, doctors to do more pain procedures that pay more. Anyway, that's a whole story, right? It's either that or it's going to be the insurance companies and how they're scamming people by not covering procedures, denying procedures. Denials are on the rise. So we've got more topics to cover as part of this series. We're hoping it turns into a series. We don't know for sure, but that's our hope, and that's our goal, is to turn it into a series where we're exposing all these injustices happening to patients within the healthcare system, and just basically shedding light on the truth that nobody wants to talk about, nobody wants to let you know about. It's all hidden from you because there's big business and big money in your suffering, really is what it comes down to. And I don't like that. I don't like human beings being used for profiting and suffering as a result of it. It really bothers me. If you're going to do that to them, then tell them the truth and let them at least know and make an informed decision. You know, I'm putting this spinal cord stimulator in you not because it's going to work, but because I make $30,000 off of it, and the company is really pushing me to put it in. Tell the people the truth. You know, that's what they deserve to know. It's their bodies that are, you know, undergoing harm for these procedures. So I just have a real ethical dilemma with it, and I just feel like it needs to be told. And nobody else is talking about it. I'm the only one talking about it. And so I really feel like, you know, God's put me in a position where I can fund a movie. I have the material, I have the knowledge, the experience to bring these truths to light. So yes, the movie is being, right now as we talk, they are interviewing the actors and actresses for the roles, and I think they're almost done. They asked me if I wanted to be involved. I said no. All that's being done in California, and they're going to shoot the movie in San Diego. That's going to be in June and July, and we'll probably have you know, the movie released in wintertime, so sometime around Christmas of this year is what we expect. So Spine Scam is the name. I will be the executive producer. Anyway, there's so much more to talk about and share with people. So
That's awesome.
yeah. Well, what was the other question? So he asked about the movie, and what else did he?
He was mentioned that he's going to be at Amelia Island.
Oh right,
Yeah,
the Shrimp Festival. So
yeah.
I'll try to make it. It's going to be tough because my daughter is applying, or not applying, but matriculating into college, and trying to spend some time with her before she leaves. And my son is coming back from Princeton this summer for summer break. So my wife and I have got a lot going on the weekends. But thank you for the offer. It means a lot.
Next question coming from Spoonie Mel on YouTube.
Spoonie Mel.
Spoonie Mel.
What is spooning? I mean, I think of spooning like two people spooning,
Yeah.
right? I don't know.
It's like Spoonie.
Maybe Spoonie Mel.
Spoonie.
Right, Spoonie Mel.
The question they asked is, how is the program at Rush Chicago?
How is the program at Rush Chicago? It's good for neurosurgery. It's good. It's not a top program. It's not a top 10, but it's probably somewhere around top 20 program in the country. There's only about 120 neurosurgery training programs in the United States. At least there used to be. I don't know what there is today. I haven't really kept up to date on the exact number, but the reason I know about them and I know about the quality of these programs is that my mentor at USC in Los Angeles in med school was Dr. Martin Weiss. And Dr. Martin Weiss was the chairman of the Neurosurgery Residency Review Committee, which is a group of, you know, top neurosurgeons and academics that would go around and assess all the neurosurgery training programs to see how good they were and make sure that they're training the residents properly and the residents are learning. And so I would spend hours talking to Dr. Weiss about all the different programs, and you know, I don't want to give you the wrong impression about Dr. Weiss, but he was a pretty straight shooter, and he would tell me which programs are really good and which ones to stay away from. And he said, you know, because of my qualifications, I only needed to look at the top 10, and the other, basically 95 programs he didn't want me to apply to because they were really bad. There's a lot of really bad neurosurgery programs out. They don't get the volume, they don't have the expertise or attendings, just horrible quality training. And so that's why I ended up at the top program, because he, I was very qualified and he knew all the chairmen and he vouched for me. And basically I got one of the 2 seats at University of Florida in Gainesville, pretty much because of him. The chairman at UF in Gainesville, Dr. Albert Roten, world famous neurosurgeon, he was the chairman. He and Marty Weiss were good friends. And when I showed up to interview for the job, Dr. Roten pulled me in the office and he said, Dr. Weiss speaks very highly of you, and can you, he said, he had behind his desk, he had all these pictures, photos of like neurosurgeons in coats and suits, and he said, can you find Dr. Weiss? So what he was doing was, he was just making sure that I knew who Dr. Weiss was, right? And that there wasn't some funny business. So immediately I saw Dr. Weiss, said he's right there, and he goes, very good. Cool. He tested me basically. That's the first thing he did, and I passed. So then he asked me some neuroanatomy questions, about things in the brain. And Dr. Roten, who was the chairman at UF, liked me in particular because my background was neuroanatomy, and I had just won an international competition called the Retzius Neuroanatomy Competition in Los Angeles. And it's a competition where the top people in neuroanatomy from around the world come at Children's Hospital of Los Angeles, and it's administered by Floyd Gillis, who is no longer there. He passed away, but he would do this anatomy test where he would do 50 questions on slides and stuff, and you'd have to identify the structures and the pathways and all the neurons and bundles. And I scored the highest score that he's ever seen. I had 49 out of 50. I missed one question, and so the second highest score was like I want to say 34. 16 wrong. Whoa. I had one wrong, but Roten liked that. He was a neuroanatomist. He did all these publications on neuroanatomy in the journals, blood vessels, veins, everything. So Dr. Roten liked the fact that I was strong in neuroanatomy. That's one of the reasons he accepted me into his program. All right, next question.
No current questions, but we do have a comment coming from Robin once more on YouTube saying, thank you for sharing your history. Sounds like politics is in every job in the world. Tough people survive, and you sure did.
Thank you, Robin. Yeah, surviving and spreading the message of hope to people that are suffering with chronic back and neck pain and now joint pain. If you know somebody with a knee that's bad or a hip that's bad with arthritis and they're recommended for replacement, check out our plasma rhizotomy first. It's less invasive. It's done in 15 minutes through 4 little cuts that big, and we're able to get rid of 95% of the pain on average is our number right now with our Duke plasma rhizotomy. 95% pain relief is the average. So sure beats a year-long recovery from a knee replacement, I'll say. All right, well, we'll be back shortly. We have a piriformis release. This is a patient who had came to me with herniated discs at L45, L5S1, and sciatica, weakness in his foot from a herniated disc. But when he got here, we checked him out, and he had tenderness in the piriformis muscle, diagnosed him with a piriformis syndrome, and told him you gotta get that fixed while we're there. And this was on Tuesday. He refused the piriformis release, just wanted the discs fixed. We fixed the disc, his back pain's gone. Leg symptoms are pretty much gone, but he's got horrible cramping, tight spasms in his buttock, which is piriformis syndrome. And so he's back for a piriformis release. And it's his left side. So we're going to get that done next. And then our last patient is a really interesting patient. He comes from India, and he's been watching our live streams for 2 years. broadcast for 2 years. And he's got 3 disc herniations in his back, but one of them is on both sides, L4-5. So we're going to go in on bilateral 4-5, I want to say left 5-1 and right 3-4.
Correct. Yep.
And we're going to do also a piriformis release,
Yep.
or piriformis on him as well. So we got 2 piriformis releases today, still to come. And we have the Duke laser disc repair for herniated discs that are causing back and leg symptoms. All the way from India. He waited 2 years. He said he saved up his money so he could come here and get it done. So he'll be our last, I think our last case for today,
I
right?
believe so.
Yeah.
Yeah.